welcome all the consultants, PG trainees and all others with us today for this monthly meeting of case discussions. To have this case discussion meeting was suggested by Curriculum Revision Committee of PGIM and the College of Chemical Pathologists of Sri Lanka plan to organize these case discussion meetings monthly in future. The aim of this activity is to discuss difficult cases and share knowledge and experience among our members. Even though we are one group, we are not getting much opportunity to discuss our valuable experience with each other, and I hope these meetings will fill that gap. I request all of you to send details of your interesting cases to college, and we will organize these meetings accordingly. I must thank all the trainees who sent cases this time with very short notice for this monthly meeting, namely Dr. Induja, Senior Registrar NHSL, Dr. Madhu Vijaysurya and Dr. Menaka Balasurya, Registrars NHSL. And I also thank Dr. Gaya Katulanda for valuable contribution for this event. Hope this will be a valuable learning experience for all of you. Over to you, Dr. Induja, Madhu and Menaka.
Thank you, Madam. We would like to thank our College of Chemical Pathologists for giving us this opportunity to present our cases. Let me start my case.
It's better to off your cameras. I think you all have low signals. Off your camera.
Yeah, this is a brief summary of our patient. Hello, can you all hear me?
Now we can hear. Start the first slide. Oh, then yantang ehena.
Can you start from the first slide? From the first slide.
Hello, can you all hear me?
Yes, we can hear now.
Okay. Hello,
Okay, Gaya.
can you all hear me?
කිසාලි දැන් මම මේ මගේ රූම් එකේ නෙමෙයි ඉන්නේ. අපි ගිහිල්ලා ආයි පටන් ගන්න විනාඩියක් දෙනවද?
Okay, okay.
හරි. කිසාලි ඇහෙනවද?
එහෙනවා දැන් හරි.
Yeah, she's a 68-year-old woman with psychiatric illness, presented with altered behavior for 2-month duration and reduced level of consciousness for 2 days. She was on lithium carbonate for more than 20 years. By this admission, she had no history of fever, vomiting, diarrhea, or fits. Her investigation revealed hypernatremia, a sodium level of 163, and serum potassium, creatinine, calcium were normal, and her thyroid adrenal liver function test revealed nothing abnormally. Her CT brain and CSF analysis were normal. So up to now, she's having hypernatremia. So we'll see the causes of hypernatremia. Usually, it is less common than hyponatremia. The causes are due to pure water depletion or combined sodium and water depletion with water loss predominating. Less commonly, it's due to sodium excess. Yeah, we can explain most cases of hypernatremia by water loss, insensible losses, gastrointestinal losses with vomiting, diarrhea, and osmosis. And patient with primary neurological disease or lack of access to water, dementia, immobility, result in hypernatremia. So the affected victims are either very young or very old. Then after finding she's hypernatremia, we have done serum and urine osmolarity studies. And she was found to have serum osmolarity of 360 with inappropriate low urine osmolarity of 183. So with hypernatremia, urine osmolarity of less than 300, like in case, suggestive of diabetes insipidus. When the urine osmolarity is between 300 to 600, it's inconclusive, either diabetes insipidus or due to osmotic diabetes. If the urine osmolarity is more than 600, that means the urine is concentrated and it is appropriate. So that is due to impaired thirst or lack of access to water. Yeah. Then if we find that patient is having diabetes insipidus, we have to find the cause. This diabetes insipidus can be complete or partial. Usually, in complete cases, plasma osmolarity is higher than the urine osmolarity, usually, like in our patient. And we all know that to differentiate complete central and complete nephrogenic, we have to administer desmopressin and see the response. If the urine osmolarity increased by more than 50%, that means kidneys are responding to the administered desmopressin. That is due to complete central DI. When there is no response, no urinary concentration after administering desmopressin, that is due to nephrogenic DI. In PAR category, usually the urine osmolarity is higher than plasma osmolarity, but still the concentration is defective. So we have to again evaluate the patient with history, brain imaging studies, or therapeutic trial of desmopressin. Then in our patient, we have planned to go for the desmopressin challenge test directly. Why water deprivation test was not performed? Because she has the baseline of serum osmolarity of 360 with a urine osmolarity of 193. So it is suggested if the baseline sodium is more than 145 and plasma osmolarity is more than 295 with inappropriate low urine osmolarity of less than 300, primary polydipsia can be excluded and water deprivation test can be skipped and direct administration of desmopressin can be done to differentiate cranial DI from nephrogenic DI. Then, the day of desmopressin test, we got the values like this. She had the basal higher serum osmolarity and sodium, and the urine osmolarity was found to have 347. And you can see after giving the desmopressin, there is a response, like urine osmolarity was increased. That means her urine is concentrated, but see, in contrast to that, this urine was increased. These two are not compatible with each other. Then there was a diagnostic confusion occurred. In normal patient, if we see the response to the dehydration and desmopressin, it is like this. If you follow the color line in normal patient, if you make them deprive of water, that is, if you make them artificially dehydrated, their urine osmolarity goes up well above 800 and they concentrate their urine. And these two categories are diabetes insipidus cases with complete category. Like there is no response at all. But after giving the desmopressin, there is a response occurs in central cases, and after that also, that means after desmopressin also no response following. in complete nephrogenic cases. Between this normal phase, cases, here you can see this orange is partial cranial and the green one is partial nephrogenic. You can see that in partial nephrogenic, the response with the dehydration phase is low. And after giving desmopressin also, there's a sluggish response. Partial cranial, the response is a bit higher. That means there is the concentration of urine, and after giving desmopressin also, 15 to 50% rise occurs. Primary polydipsia, they concentrate urine, but not to the normal level because there's a long high water load and the maximum concentration ability of the renal tubules are lost. That's why they can't achieve maximum, but they naturally concentrate urine compared to this diabetes insipidus category. This is what I explained. So in our patient, although there was a diagnostic confusion, there was a rise between 15 to 50%. So we assume she might be having a partial cranial diabetes insipidus, and then it was suggested to give a trial of desmopressin, and measurements were made for serum osmolality, sodium, and urine osmolality. But there was no clinical or biochemical improvement noted following desmopressin. What happened? The sample was, we have instructed for proper sample collection, but it was not collected in the week. The patient was catheterized, but the sample was, the catheter was not clamped properly and the sample was not collected. We will discuss that later. Then we repeated the direct session of our chemical pathology registrar, and on that day of repeated desmopressin challenge test, you all can see after giving desmopressin, there is no response. Almost the urine remains diluted with increasing urine output. That means kidney is not responding to the desmopressin at all. So these results are compatible with nephrogenic diabetes insipidus. And you all can remember that patient was on long-term lithium therapy. Most frequent side effect of lithium is nephrogenic diabetes insipidus. Patients who are on long chronic lithium therapy can develop resistance to antidiuretic hormone. In this case, lithium was discontinued and treatment was switched to risperidone and clonazepam. Sodium diet was started. Further discussion will be carried out by our consultant chemical pathologist, Dr. Gaya Katulanda.
Good afternoon. So this is a straightforward case. If like we had done water deprivation test correctly from the beginning. So in summary, this is a 68-year-old woman on oral lithium for more than 20 years, presenting with altered behavior for 2 months, and preliminary testing showed high serum sodium, high serum osmolality with a serum urine osmolality of less than 300. So the diagnosis of diabetes insipidus is straightforward. Then in the history, this more suggestive of this to be nephrogenic origin, and in imaging also cerebral brain imaging didn't show any like tumors or any pathologies, and there is no history of head trauma. But somehow like we couldn't diagnose at in the first report, according to the first report, we came to diagnosis of partial cranial DI, and then only by repeating tests we could diagnose nephrogenic diabetes insipidus. So I have compared the urine osmolalities here. In the test 1, urine osmolalities were higher, and during the test 2, we got very low urine osmolalities. So the real reason is ward staff has not followed up instructions properly despite us giving proper instructions. So this is a very commonly requested test. And usually we give instructions to the patient, but this is a psychiatric patient, nurses and doctors as well. But we realize that in difficult situation that is not enough, but our presence is equally important. So we have done this kind of even in catheterized patients before, but this time we failed this and we had to do a repeat testing to confirm nephrogenic DI. Like it can be like congenital, and there are other drugs can cause this, like amphotericin B, demeclocyclone, ofloxacin, orlistat, rifampicillin, cisplatin. These are commonly given drugs which can cause NDI, and low potassium and high calcium can cause this, but in our patients both were normal. And tubular diseases such as polycystic kidney disease, chronic pyelonephritis, obstructive uropathy, sickle cell nephropathy, and renal amyloidosis can cause NDI. And just to show what happens in the collecting duct, so this is a principal tubular cell, which is the basolateral membrane and blood vessel. And this is the apical side that tubular fluid is carried out. And then ADH binds to ADH receptor, and it has a G protein, and it produces cyclic AMP to adenylate cyclase, and the cyclic AMP phosphorylase protein kinase A, and which pushes aquaporin 2 receptors to the apical membrane, and through them water is released, and then passes to the through aquaporin 3 to the capillaries. So when lithium is given, so this lithium is freely filtered and reabsorbed by ENaC of collecting tubule ducts. ENaC is epithelial sodium channel. Then the absorbed lithium accumulates within the cells at cytotoxic levels. Then this lithium, this accumulated lithium decreases aquaporin 2 and aquaporin 3 production, but the exact mechanism is unknown yet. So that is how it causes NDI, but NDI can occur within 8 weeks of starting therapy or up to after 10 to 20 years. So there are few treatment options. In our patient, lithium was stopped and thiazides were started, but it is not easy to stop lithium in all the patients. So you can use thiazide, amyloid, and modulators of renin-angiotensin aldosterone systems such as captopril, spironolactone, and angiotensin receptor blockers. So these are the references we have used, and then this is like open for discussion. So if you have any queries, you can ask any question. In the first instance, by looking at this results, we could have realized this test gone wrong, but somehow we missed it, and then patient was treated with desmopressin for some time, and then we all realized that like something has gone wrong. So this shows the importance of like our involvement in dynamic function tests like these. Kisali.
Yes, Gaya. I think it's better to move to next case.
Okay. Next
Yeah,
is
yeah.
okay, our next case is recurrent admissions with hyperamylasemia. Madhu, over to you.
Okay, we'll discuss the case. So this patient was a 70-year-old male who was admitted to our surgical ward, who was an ex-alcoholic and smoker. He presented with non-specific epigastric pain of mild to moderate intensity with dyspeptic symptoms. He also had a worsening shortness of breath with productive cough. He was a patient who had presented multiple times to the hospital with these similar type of epigastric pain in the past. He had no records and had defaulted follow-up. And he was also a patient with hypertension, bronchial asthma, COPD, and pulmonary TB. During the ward stay, his investigation showed that AST, ALT, bilirubins, total proteins, albumin, and creatinine were within normal range. But his serum amylase was 694, which was more than 5 times the upper limit of normal. Other investigations such as troponin, calcium, magnesium phosphate, full blood count, CRP-SR were all normal. And this patient was managed as acute pancreatitis with infective exacerbation of COPD during the ward stay. After 1 week, he was discharged, and during the clinic visits, monthly carried out, showed that there was a persistent increase in persistent elevated serum amylase in this patient, despite the serum creatinine except this 1.3 milligram per deciliter. His renal functions were quite okay. Then he was referred to our chemical pathology unit to identify the cause of persistent or chronic hyperamylasemia. By this time, he had undergone some imaging. Ultrasound abdomen showed a fatty liver, grade 2, with mild hepatomegaly, a right-sided renal cyst, and the pancreas was normal. Upper GI endoscopy revealing HIL3 hiatus hernia and mild enteral gastritis. CECT abdomen and pelvis showed renal cortical cyst, but the pancreas was normal again. So, with all this, when the patient came to us, our differential diagnosis were in this patient, some type of pancreatic disease that will present like this, like acute and chronic pancreatitis, salivary disease like chronic alcoholism. Since this patient had gastritis and a hiatal hernia, maybe it could contribute to the elevated amylase. And since it was an alcoholic patient, maybe there might be a component of alcoholic hepatitis or cirrhosis. And the benign condition we thought of was macroamylasemia. So we went ahead with the investigations we do with simple tests such as urine amylase, and we calculated the amylase creatinine clearance ratio. By this equation, urine amylase over serum amylase into serum creatinine over urine creatinine into 100%. It gave us a ratio, a percentage of 0.4%. So normally, the amylase clearance ratio is 3 to 5% in the normal population. But if the value is less than 1%, it is very suggestive of macroamylasemia. Next, we also did the polyethylene glycol precipitation of serum amylase using PEG 6000 solution. We diluted and added in the 1:1 ratio, and we got a post-PEG amylase value of 10 units per liter. The pre-PEG value amylase levels was 644, which was the baseline amylase that this patient was having.
and the recovery was calculated with 1.5% in the supernatant. So, in interpreting this value is definitely suggestive of a macroamylasemia. The cutoff was mentioned in one of the articles as less than 30%. So, this is quite indicative of a macroamylasemia. So, coming to amylase as a molecule, it consists of two isoenzymes. The P type is mainly in the pancreas, and the S type is mainly in the salivary gland. It is also secreted by some cells in the lung, fallopian tubules, lacking mammal glands. The clearance is renal. The small molecule passes through the glomerular filtrate as in the glomerular filtrate, and it undergoes partial reabsorption. And they have also found out another method of clearance in the reticular endothelial system, mainly by the liver. So that is the clearance of amylase. With all this, the half-life is 10 to 12 hours and elevations may persist to 3 to 5 days. Coming to macroamylase is this SOP type of amylase that is linked to immunoglobulin or complex polysaccharides. The molecular weight of this macroamylase is 150 to 1000 kilodalton. The normal is around 50 kilodalton. And this is not filtered by the membranes. So in these type of patients, macroamylasemia should be considered in any patient with persistently elevated or inappropriately raised levels of serum amylase activity with normal serum lipase with unimpaired renal function. In our setting, we did not have serum amylase creatinine. Then other confirmatory tests such as gel filtration chromatography and electrophoresis or isoelectric focusing are also available.
Okay, thank you, Madhu. So, in summary, this is an elderly man presenting with recurrent episodes of abdominal pain, and he had persistently elevated amylase as well. He was ex-alcoholic and ex-smoker, and those two factors are suggestive of pancreatitis, but there are no other features in his examination suggest pancreatitis, and his renal function tests were normal, and but we didn't have lipase, so we have no idea, but if we did, it has to be normal. We know it now, and this shows diagnostic workup of macroamylasemia. It's a diagnosis by exclusion. If serum lipase has to be normal and urea amylase has to be normal or decreased, and then renal functions should be normal, then we do clearance ratio, and if it is positive, then we have to do another test, maybe electrophoresis. So we have done PEG precipitation, then we come to the diagnosis of macroamylasemia. So this is not uncommon case. In 10 cases amylase, usually one is macroamylasemia. So this is mostly benign if asymptomatic, but rarely there are cases when macroamylasemia is associated with abdominal pain. So our patient also had something like that. And the most important thing is to avoid diagnostic confusion. So you have to keep on doing amylase, and then whenever this patient comes with abdominal pain again, admits to another hospital, then they will investigate thoroughly. So patient should carry a diagnosis card about his condition and should not be investigated unnecessarily again. So each case of hyperamylasemia where you don't have pancreatitis is not a macroamylasemia, and it's not an investigation ignore, because it can be elevated in many conditions unrelated to pancreatitis. So salivary gland lesions, mumps, calculus, irradiation, sialadenitis, maxillofacial surgery, post-surgery, and it can be elevated in certain tumors lung cancer, esophageal cancer, breast and ovarian carcinomas, and in burns, in diabetic ketoacidosis, pregnancy, renal transplantation, in cerebral trauma, and due to drugs such as opiates. So that's all for that case, and then we'll move to the next case. Sorry, I didn't give a chance to ask questions if you have any questions. Okay. Shall we move case?
Yep. Can I ask?
Yes, yes.
Gaya, I don't know what is. I halfway through like started listening to this case, but anyway, what came into my mind is now what is the cause for high amylase in this patient initially? What was the cause?
No, even in the initial presentation, all the other investigations were normal, AST, ALT, and renal functions. So, but he was discharged, and in the clinic, amylase was done continuously, like once a month, and all each time amylase was high.
But what was the reason to do amylase?
Specific abdominal pain. Shall I put it?
No, I don't have the slide. Like,
No,
okay.
yes, madam.
Now
I will show you the slides again. This is the history. Madhu, can you?
Madam, this patient came with this non-specific epigastric pain, and one of the DDs initially was acute pancreatitis. Like going back retrospectively, since everything was normal, towards day 1 week, they managed as acute pancreatitis, but retrospectively, the cause for the abdominal pain might have been this hiatal hernia. Heals 3 is kind of a moderately severe hiatal hernia, madam. So the epigastric pain and the non-specific symptoms might have been due to that.
Oh, right.
Imaging was all normal, madam.
Hernia, right. Okay. So was it operated?
No, madam. Managed just nil by mouth with IV fluids at acute pancreatitis regimen, madam.
Ah, right. Okay, right. Thank you.
Thank you, madam. Next case is LDH stimulated adrenovenous sampling, not easy to interpret by Dr. Menaka.
In this presentation, we are going to present 2 case scenarios. The first case, a 34-year-old woman admitted with history of palpitation, shortness of breath, and headache for 1 week duration. There was no similar history in the past, no muscle weakness or numbness. She was not on any long-term medications, and there was no family history of hypertension, stroke, or sudden death at young age. On examination, her BMI was 22 kilograms per meter square, and the blood pressure was 6/100. Rest of the cardiovascular examination, abdominal, neurological, Musculoskeletal examinations were normal. During hospital stay, her blood pressure was controlled with 3 antihypertensives at their maximum doses. Initial biomedical investigations revealed hypokalemia. It is the evaluation of secondary hypertension. Here I have mentioned few common causes for secondary hypertension like primary hyperaldosteronism, renal artery stenosis, pheochromocytoma, hyper and hypothyroidism, Cushing syndrome, and their clinical features, screening test and confirmatory test, and identification of patients who need extensive evaluation for the secondary hypertension is critical, and proper history and examination is needed. So regarding the primary hyperaldosteronism, it is one of the most common causes for secondary hypertension, and it accounts for more than 10% of patients with hypertension, and it is commonly caused by aldosterone-producing adenomas, unilateral or bilateral adrenal hyperplasia. Rarely, it can be due to familial hyperaldosteronism like glucocorticoid remediable disease and adrenal carcinoma. Diagnosis is very important here because of its higher prevalence and association with higher rate of cardiovascular morbidity. And specific treatments are available in reversal or improvement of hypertension and resolution of increased cardiovascular risk. So let's see what Endocrine Society guidelines describe about the case detection testing for primary hyperaldosteronism. As they recommend case detection testing indicate for primary hyperaldosteronism in patients with hypertension and hypokalemia, resistant hypertension, adrenal incidentaloma and hypertension, onset of hypertension at a younger age, and severe hypertension, and whenever considering the secondary hypertension. So they have recommended aldosterone-renin ratio, including individual values for both plasma aldosterone concentration and plasma renin activity as the screening test. So whenever patient is having plasma aldosterone concentration less than 10 or plasma renin activity more than 1 nanogram per milliliter per hour, primary aldosteronism is unlikely. And if patient is having plasma aldosterone concentration equal or more than 10 and renin activity less than 1 nanogram per milliliter per hour, primary aldosteronism is likely. However, as the ARR is a screening test, it is having false positive and false negative results. So confirmatory testing is needed. The glucocorticoid suppression test and saline suppression test. And however, when the patient is having spontaneous hypokalemia and plasma aldosterone concentration is equal or more than 20 with the suppressed renin level, primary aldosteronism can be confirmed without confirmatory testing. So moving back to our patient, so why we have suspected secondary hypertension in our patient? Because she had hypertension associated with hypokalemia and severe sustained hypertension with BP more than 50/100. And her age was closer to 30 years and she was non-obese with a negative family history of hypertension, and there was no other risk factors for hypertension. So initial investigation revealed hypokalemia with significant kaliuresis, and her renal function and liver tests were normal, thyroid function was normal, and ODST was suppressed. So they proceeded with the aldosterone-renin ratio, and aldosterone was 45 nanograms per deciliter with the plasma renin was 0.38. The aldosterone ratio was 180. And here, as the patient had spontaneous hypokalemia with aldosterone more than 20 in the presence of suppressed renin activity, primary hyperaldosteronism was confirmed without confirmatory testing. And they proceeded for subtype evaluation, and CCT abdomen and pelvis was carried out, and it revealed an enhancing nodule measured 0.8 in the right adrenal gland with the normal left adrenal gland, and density and the washout indices were compatible with adrenal adenoma. So she was discharged on processing nifedipine and hydralazine and oral potassium supplements, and she was followed up at the clinic for the evaluation of primary hyperaldosteronism and blood pressure control. So regarding the subtype evaluation of primary hyperaldosteronism, adrenal CT scan is the recommended initial testing for the subtype testing to exclude the presence of large adrenal mass suggestive of adrenal CA and to identify the adrenal anatomy. However, to differentiate the bilateral disease from the unilateral disease, AVS remains the gold standard test, and AVS carries higher sensitivity and specificity than the adrenal CT. So whenever patient is confirmed with the primary hyperaldosteronism in the presence of either unilateral or bilateral disease and patient is willing for surgery, AVS is indicated before going for the surgery. However, when the patient is less than 35 years of age, with the imaging suggestive of unilateral disease, they can proceed with the surgery without going for the AVS. So in this patient, they have carried out non-stimulated sequential bilateral adrenal venous sampling. Little bit about the interpretation. To demonstrate successful cannulation, first we have to calculate the adrenal vein to cortisol ratio, and it should be more than 3. And to confirm the unilateral aldosterone excess, first we need to calculate the cortisol to aldosterone ratio in each adrenal vein, and then the lateral index is calculated. So in this patient, as you can see here, successful cannulation is achieved in both veins, and cortisol corrected aldosterone ratio is comparatively higher in the right adrenal vein. So the lateral index, lateralization index was 16.69, and the AVS lateralized the aldosterone excess to right side, and it was compatible with the imaging, and patient underwent right side adrenalectomy, and the histology was compatible with adrenocortical adenoma. So let's move to the case 2. He is a 64-year-old male with a background history of type 2 diabetes mellitus for 18 years and hypertension, microalbuminuria, and osteoporosis. Referred for the evaluation of secondary hypertension due to early onset hypertension at 40 years of age. And there was significant family history of young hypertension in first relatives. The mother had hypertension since the age of 20. And there was no symptoms suggestive of pheochromocytoma, Cushing disease, or no features of obstructive sleep apnea. So why we have suspected second hypertension in this? Because we had severe resistant hypertension needing 3 antihypertensives with their maximum doses, and significant family history of early onset hypertension and hypertension at the age of 40, and he was non-obese. And investigation revealed, actually initial investigation were not significant, and renal function tests were normal except the microalbuminuria, and thyroid function tests were normal, ODST was suppressed, and 24-hour urine metanephrine was also normal. And ARR was carried out, and aldosterone was 40.3 with the very low plasma renin activity of 0.07, and ARR was 204. However, this patient primary hyperaldosteronism is likely, but as the aldosterone level is less than 20, and as there is no spontaneous hypokalemia, here we need to confirm the primary hyperaldosteronism with the confirmatory testing. However, the clinicians proceeded directly for the subtype evaluation without case confirmation. So in the imaging, they have found a left suprarenal mass in the lateral limb measuring 0.9 into 1 centimeter, and density and washout indices were suggestive of adrenal adenoma, and another small lesion in the body of left suprarenal gland, which was suggestive of incidental lipoma. So they have carried out stimulated bilateral adrenal sampling. Here for the successful cannulation, adrenal vein to peripheral cortisol ratio should be more than 5. To confirm the unilateral aldosterone excess, lateralization index should be more than 4, and when it is than 3, it is bilateral aldosterone excess, and when it is between 3 to 4, it is considered as inconclusive. So in this patient, successful connection achieved in both adrenal veins. And as you can see here, cortisol corrected aldosterone ratio is comparatively higher in the right adrenal vein, and the lateralization index right to left was 4.8. So the AVS lateralized the aldosterone secretion to the right adrenal. So, because imaging has shown a lesion in the left side, and AVS lateralized the aldosterone secretion to right adrenal. However, so what are the possibilities for this patient? So it can be right side adrenal aldosterone producing adenocontrolateral incidentalloma, or right side unilateral adrenal hyperplasia with contralateral incidentalloma. Little bit about stimulated AVS versus non-stimulated AVS. Stimulated AVS carries higher sensitivity than the non-stimulated AVS. It can be carried out with posentropine stimulation, which can be given as an infusion or the bolus injection. And stimulated AVS minimizes stress-induced fluctuations in aldosterone secretion during sequential AVS, and it maximizes the gradient in cortisol from adrenal vein to inferior vena cava, and thus confirm the successful thumping of the adrenal vein, and it maximizes the secretion of aldosterone from APA. So challenges we face during this stimulated AVS, main concern was the availability of the cosintropine. However, this patient was lucky enough to get down the cosintropine. And the other thing is regarding the interpretation, absolute values are mandatory, and all that samples should be at 1:1, 1:10, and 1:50 dilution. And for these assays, for the cortisol, here we have used competitive chemiluminescent immunoassay, and it has analytical measurement range from 27 to 1649 nanomoles per liter, and manufacturer validated maximum dilution was 1:8. And for the aldosterone assay, analytical measurement range was 0.9 to 100 nanograms per deciliter, and the manufacturer validated maximum dilution was 1:10. So as you can see here in this patient, in both adrenal vein, cortisol concentration was more than 20,000. So we had to go for the dilution beyond the manufacturer validated dilution. And same as in the right adrenal vein, we had to go for the 100 dilution. So further discussion will carried out by Gaya madam. Over to you.
Thank you.
Gaya, we can't hear you. Gaya? Gaya, we can't hear you. I think Gaya will join again.
Share करूँगी. Sorry, there was a problem. Can you all hear us now?
Yes, sir, we can now hear.
Okay, there was a problem here. Like, sorry for that. But you were listening till this.
I think we miss only your discussion.
No, I didn't start my discussion.
Okay.
Okay. So I will compare the two presentations. So case 1 is 34-year-old female with a blood pressure of 100 and but controlled with 3 medicines, and she had low potassium and plasma aldosterone was higher than the decision limit of 20. It was 45, and plasma renin activity was suppressed, and aldosterone to renin ratio was 118. And actually, as Menaka said, like we don't need to do more confirmatory tests. So we can like straight away diagnose with these findings. And the other patient was 64-year-old male and had high blood pressure for 24 years. And he has early renal damage as well, and has a first degree relative with young hypertension, who is a young hypertensive, and aldosterone was 40. So this is not very high to like straight away diagnose primary hyperaldosteronism. But his plasma renin activity was suppressed, and APR was very high because of this very suppressed renin activity. So in this patient, you can't diagnose primary hyperaldosteronism with this. So this patient needs a confirmatory test. The easier and commonly done one is the saline loading test. So if this patient underwent saline loading test, we are not sure like whether this was would be a confirmed case or not. Anyway, then both patients, we had to do AVS to find out the location of the aldosterone secretion. Then case 1 findings were compatible with imaging, and the surgeons went ahead with removing the adenoma. But in the case 2, AVS findings were not compatible with imaging, and the secretion was lateralized to the opposite side of the adenoma. Then what are the things against, and the gray things are lateralization index was 4.8 and the cutoff is 4.1. And if it is lateralization index is if less than 3.1, it should be bilateral secretion, and 3.1, 4.1 is if we get value between 3.1 to 4.1, so we can't come to a conclusion. But the thing is, we had to do massive dilutions to get a value here. Even so, we are not sure whether it had any effect on the final values. Actually, this patient, the intervention was done at NHSL, and usually we send our aldosterone samples to MRIO Colombo North Teaching Hospital. So this sample was sent to Colombo North Teaching Hospital, and actually they repeated this as well, and then had to go for 1 in 100 dilutions both times. Then actually the endocrine team was also confused with the results, and then but it is probable that patient has an incidentaloma on one side and unilateral hyperplasia on the other side. So it's it is the most probable thing for this patient. patient can have a adenoma which is not diagnosed by imaging on the opposite side, but the one diagnosed during imaging can be a incidentaloma. So the patient is awaiting surgery or any other procedure, and so we are not sure about the final diagnosis. But if we underwent saline suppression test at the beginning, we could have excluded it if aldosterone became less than 10, or sometimes, like as expected, anyway, his aldosterone level is high on one side, so can be a confirmed case. And the reason for going for ACTH stimulated AVS is to increase the sensitivity. So if we underwent normal AVS, then we would have not get this higher value. And again, anyway, this is the first, like after a long time, we got a stimulated AVS. Usually AVS is done without stimulation in Sri Lanka. And these things Menaka also explained that we don't need to do AVS if the patient was less than 35 years, had hypokalemia, had marked aldosterone excess and unilateral adrenal lesion, then we could have like gone for surgery. And the important thing is this patient had only one aldosterone plasma renin ratio. So you all know this is not a like very easy test or easy to test, which is easy to interpret. So the results are affected by many factors. There are many false positives and negatives. So a lot of medications, plasma potassium level, renal impairment, dietary sodium intake, and there are many more things which can affect the results, can give false positives or false negatives. And sample collection also need to be very, very standardized. And analysis also, as we explained, it is not easy. Then this is not a commonly done test. And in Sri Lanka also, this is done in only 2 government institutions, MRI and Colombo North Teaching Hospital. I am not sure whether this is done at other places, but usually we send samples to those 2 places. And this, if APR is inconclusive, if aldosterone is not compatible, and if you have any doubt, then best thing is to repeat. You have to repeat it. You may have to repeat it several times, but still you have to do it, because the diagnosis is very important. This is a treatable cause of secondary hypertension. And if you neglect this, if you ignore this, patient can have severe side effects in the cardiovascular system. And if you do the surgery later, you will not be able to reverse it. So you should not postpone, but do repeat testing and somehow conclude at the diagnosis or exclude the diagnosis. So repeating and doing saline loading test, which is a very simple test. You have to get the patient down, give a saline, and then do the APR, as same as APR. Then by doing repeated testing, you have to come to a conclusion. And if that is also very difficult, then you can go for AVS. Okay, so that's all for that case. And if you have any questions, please come up with those. That would be very constructive, because we are also like come to like exact diagnosis here.
Gaya, I think there was a question from Gaya.
Okay.
In a chat box.
Okay, we'll check it.
They are asking, did you have any imaging?
No, the thing is, we don't have imaging. So actually this was discussed in MDT with endocrinologists and radiologists. No, This was
And madam, that was not regarding
No,
this
no.
case,
No,
the
no.
previous case. Did you have any imaging findings such as CT or ultrasound scan for acute pancreatitis?
Sorry. For acute pancreatitis, imaging, chronic macromyelation.
Yeah, no, madam, we actually went, the imaging was done in the form of ultrasound abdomen and CECT abdomen, both were normal. I put it on my slide, one slide, madam. Is there anything?
Okay. Yeah, thank you. Sorry, I think I missed that point. So that's what I wanted to ask you, whether you had any imaging findings which is suggestive of the pancreatitis for that
No.
patient, because, oh, right, that's fine. Thank you.
It's normal in both ultrasound and CECT, madam, but the upper and GI endoscopy showed a mild antral gastritis and a hiatal hernia of Hills 3 category, madam.
So that may be the reason why that patient having repeated symptoms of abdominal pain.
Yes, madam, it was attributed to that.
Okay, so they arrived at that diagnosis, and then macroamylesia is something that you found separate to that. Okay, thank you.
And if you have any questions, you can
This
forward
is
to Gaya
regard
madam.
the second case about ARR. There are two cases actually. The second case had normal aldosterone, and it was inconclusive. So I'm talking about that case. Was the potassium corrected when the aldosterone and renin done?
No, madam, potassium was normal from the beginning. That patient,
Okay.
potassium was normal, but aldosterone was marginally like elevated, 14, not marginally, it was high. If it is more than 10, we consider it as high, but it has to be 10.
Yeah, usually now in the first case, what about adrenal hyperplasia in the second case?
Yes, madam, it is a possibility because secretion is unilateral. Then adenoma is, the incidentaloma is on the other side.
Yeah.
Then it's probable to have adrenal hyperplasia on the right side.
Right side, no?
Incidentaloma is on left side.
Possible cause. And usually when you do this ARR, do you correct the potassium? How
Yes,
much
madam. Yes,
do they do? The clinicians, they don't, they don't listen to this. When I was at NHSL, they hardly correct the potassium. Like when they send the samples, before sending the samples, they should correct the potassium level, no? Most of the patients, they have hypokalemia. So according to literature, you should correct the potassium level to do the ARR. So was the potassium corrected in the first case? Now the second case?
Yes, madam. Patient was on oral potassium supplements, and potassium was corrected before the ARR, madam.
Right, good. Thank you.
So in the hyperplasia, it could be a unilateral. Most of the times a bilateral, no hyperplasia.
Yes, but it can be unilateral.
It can be in unilateral, and there is an incidental loma on the other side. So maybe it showed like an incidental loma because of the hyperplasia. You know, like, so it could be very rarely unilateral.
Okay, thank you.
Are there any other questions to be asked from the team and the presenter? Okay, so in the absence of any more questions, I would like to conclude the session. Before that, this is the first monthly case discussion organized by CCPSL. Before thanking the speakers and the participants, I would like to invite all the other trainees and trainers to I mean, if you have any interesting cases like this, if you come across, please inform the college so that we can arrange, we can organize a session, case presentation session like this. We will be conducting these sessions monthly. So please inform the college if you come across this type of, and if you are willing to present this type of case presentation session. So to conclude the session, first of all, I would like to thank Dr. Gaya Katulanda for guiding the trainees and conducting the discussion sessions. Next, a special thank goes to Dr. Madhu Menaka, Registrars NHSL, and Dr. Induja, Senior Registrar NHSL, for their excellent case presentations. Finally, I thank all the participants who joined with us today. And again, I would like to invite to inform us if you have any cases and if you are willing to present cases like this in another case presentation session. So hope to see you again in a similar session in 1 month's time. Thank you.
Thank you.